All right, everyone. Well, thanks again for joining us. I have a very special guest today, our president, Mike Smith, here at the Brokerage Inc. And we're going to be talking about the conference that we just had at the Capitol from NABIP, which, if you don't know about the new name, that is the National Association of Benefits and Insurance Professionals. Did I get that right?
You did.
They drove that into us while we were there, reminding us about the name change. We're talking about what was previously NAHU or NAHU or NAHU. They made lots of jokes about that as well. But it was a great conference, a great time to be with professionals in our industry and also legislators. So we wanted to bring Mike to you guys today to talk about what was discussed there, what is in the works, what we are advocating for on your behalf. So, Mike, thank you so much for joining us today.
I'm glad to be here. You know, it's exciting for me because I used to go to these CAP conferences in D.C. by myself for many years, and I'd come back to the office and tell people, wow, it was really great. You know, it was exciting. The food was wonderful. We talked to these representatives. We heard from these people at CMS, and, you know, the staff would look at me like, oh, that's great. And then it would just be an afterthought. And then to be able to have 5 other people from our team join us in D.C., when they say seeing is believing, well, you tell me, and what is your overall impression?
First of all, the kind of folks that this attracted, my first observation was these are folks that really care about the industry. And they're really successful people. And I made a comment to Ethan, our recruiting director, because we had just been having really good conversations at the booth. You know, I was like, these folks are next level. The folks that are paying to come all the way up here to advocate for our industry. So I was really impressed with that. And you can tell that there's a history there of folks that have gone for years and years and years. You know, I met with some of your friends that Saturday night, and just to see their commitment to it, it definitely made an impression on me.
That's good to hear you say. You know, something that I learned very early on in this business was that the smartest people are the ones that tend to have more success in this business. And so one way to get smart is hang out with other smart people.
Yeah.
They kind of rub off on you.
Right.
And that networking is invaluable, not to mention that it's introduced me to so many mentors throughout the year. So for those people who are listening to our message this morning or this afternoon, wherever they may be, I would just encourage them to check out NABIP, give it a look, and perhaps become a member and join us in D.C. next year. It's truly an amazing experience. And not to mention that when you walk away, you have a different perspective about how things get done in this country. You know, we have a constitution, we elect our officials, we send them up there to D.C., and then usually our opinions are painted through the press. And oftentimes that's a very skewed opinion of really what's happening. And when you've got news networks competing for airtime or newspapers for press, what do you think they're going to do? Tell you cute little fun stories? That's not going to do much. They're going to gin up some controversy. Yep. And when you go to D.C., though, what you find is that there's actually a lot of bipartisan caucuses that are actually working together to try and bring solutions. And, of course, you know, with health care and health insurance, Medicare, we're right in the thick of that. And it's consuming about 20% of our gross domestic product right now. I don't know of another widget in our country that consumes 20% of our GDP. And so when we go to D.C. and advocate on behalf of our customers, on behalf of our brokers, it's extremely important. And I was super pleased that you came along with several other of our friends and of course, people that work here at the brokerage to come back and now understand what I've been trying to tell people, that we're doing what we can to advocate and make a difference.
And everyone, Mike got a award while we were there, the Spirit of Independence Award. Big honor. I got to just kind of see that happen, and so we want to definitely say congrats for that. That was really awesome.
Yeah, it was quite a surprise, and you know, and I look at that not as an individual award, but one it's a team award, not only from people that work here at the brokerage, our spirit of independence.
Yeah.
And you know, how many times have we been asked in the last 2 or 3 years, hey, I heard y'all are selling. When are y'all going to sell?
Yep.
And what have we said? We are going to remain independent. And so that award is significant to me in a lot more reasons and a lot more ways. But last 4 years as I've been the chairman of the Medicare working group there, I've fielded a lot of phone calls from a lot of agents from coast to coast about, hey, why are we being included in the definition of a third-party marketing organization? And just having to spend a lot of time and energy to try to calm people down and bring perspective back into the equation. So that award was a culmination of a lot of people's efforts, and so I share that with everyone.
Well, it was definitely an awesome moment, and they now named that after Janet Troutwine. That award is now in her name, and so it was cool to see her give that to you. It was a really cool moment.
Very special. She's been a good friend for a long time.
Yeah. So, all right. Well, let's now pivot and start getting into the talking points from the event, as well as what we are advocating for on behalf of you guys that are listening. And really, I'm just going to be a listener in this. I'm just going to get Mike going. He is the expert on these things, and just ask questions as they come up. I'll try to be a devil's advocate here and make a conversation. So, Mike, let's go.
Okay, well, my comments mostly will be focused on health-related and Medicare-related issues because that's what NABIP does. We also have other professional associations, the NAFA, for example, and they may advocate for more things financial-related, life insurance-related, annuity. So my comments will be constructed, and I'll just go through some of these because, the 118th Congress is in session right now. In many of our Hill visits, the representatives that we set appointments with were voting on issues. So these are very fresh things. I'll first center my comments around things related to employer group insurance. And in the United States, depending on the resource where you want to look at for numbers, we have anywhere from 160 to 180 million Americans that get their health insurance through an employer-sponsored plan. And when you look at the IRS and what they allow for tax deductions, besides a mortgage interest deduction, one of the largest deductions that you can have is through an employer group health plan. Oh, it's just like we here at the brokerage. We have a group health plan. We are allowed to pay for and deduct the premiums for that group health plan. And then when you receive benefits, those benefits are also received income tax free. Now, on the other side of that, when you're the IRS trying to figure out where to collect money, and then you start thinking about, well, the Part A trust fund might be stressed. All these people have their hands out. One of the first things the IRS is going to do is look at the largest tax-deductible items, which include group health insurance. So one of the things that we talk about is modifying that so that we can make sure to preserve the employer exclusion. What that exclusion allows for is for employers like the brokerage to pay for and deduct the premiums. And if that gets taken away, well, sure, the IRS will be able to enjoy a lot more revenue because we will be able to exclude those premiums anymore. We'll have to pay taxes on that money. But then there may be 160 million to 180 million employees that lose their coverage. And so many employers are already spending so much money on premiums, they can't afford the premiums. And if you take away that tax deduction, then they're just going to 86 the plan. And then what'll that do? That'll make a lot of people uninsured, which will then redirect them hopefully to an ACA individual or family plan, which would probably be heavily subsidized. And then what? They're going to have more tax subsidies that they have to pay.
Right.
So you can't rob Peter to pay Paul in this issue. So preserving the employer exclusion tax is one of our strongest talking points.
If I can ask, who is saying that should be removed? Like, who is advocating? Like, who is on the opposition here?
Anybody that's in the government that's in charge of the Congressional Budget Office or anyone related to an agency that manages revenue. And when they look at revenue, they look at what are they losing. Another big one to take it to another direction, I mentioned NAFA and how they advocate for financial issues. The internal cash buildup of a life insurance plan, what a beautiful contract.
Mm-hmm.
And when you can build up cash value as a supplement to your retirement or allow for that plan to pay out for qualified long-term care expenses, that's another huge deduction where there could be tax revenue generated that's not happening.
Right.
And the IRS is going to look at anywhere they can to find money. And the employer tax exclusion is a big one where they think they could gain a lot of money back that's being lost to current tax deductions.
Wow. Okay. Interesting.
Yep. So that's a big one right there. Another one of our main talking points is what's known as a site-neutral rule. That's site as in S-I-T-E. Now, what this is involving, let's say that you go to the doctor, you have a chest cold, and they do an x-ray in the doctor's office, and that x-ray and that chest cold is diagnosed and billed at, say, $300 total. And you may be responsible for a $20 copay or whatever your plan determines, but it's a $300 charge. But what we're seeing now is a lot of these hospital groups are buying up doctor groups. Yep. And instead of performing those x-rays in the doctor's office, now they just say, well, Gillan, we think you might have pneumonia. We're going to send you over to our outpatient facility across the street to have a chest x-ray. So they may charge you $200 for that office visit. But guess what? When you go across the street to get the x-ray, there's another $500. So now your total charge went from $300 to $700. Well, who's going to pay that claim? The insurance company. And the more claims that they pay out, what happens upon renewal? Does the premium for the plan go up or down?
Goes up.
And what's the number one complaint? Healthcare expenses are too much.
Right.
And so what we want to do is bring transparency into the equation, where if you want to have that chest x-ray performed at the doctor's office or across the street at their outpatient facility, that it is exactly the same cost. And the only way that we're going to get there is to put transparency on the table. Let me ask you a question. When you go buy a pair of blue jeans, do you look at the price tag?
I do.
Do you think that there's a difference at the cost of, say, TJ Maxx versus Neiman Marcus?
Sure.
Okay, so same thing. You're shopping for services. You're shopping for products. And yet when we buy healthcare, we have no idea what the cost is. And ironically, the cost is determined by a third party that wasn't even involved in the transaction and sent to you in the form of an explanation of benefits 3 weeks later.
Mm-hmm.
We don't buy anything in the United States that way, and yet we accept that 20% of our gross domestic product is managed in that type of a shopping atmosphere. So we don't have transparency. That's another big one of our talking points. Bring transparency into the equation so that people can shop for their services, and these site-neutral things will cost the same from one place to another. So both of those, the employer exclusion and site-neutral rules, significantly impact the cost of premiums, and we all struggle to bring affordable health insurance to the marketplace. We need to get a handle on the cost of care in order to preserve the cost of the premiums.
Yeah, I remember when this was brought up in the room, there was some confusion among some folks out there. So I'll try to bring you their questions for those that didn't get to hear those questions. I remember one lady said, what's the big deal? She said something along the lines of, if I go to Target versus Walmart versus Costco to get milk, of course the price is going to be different, right? And I believe the CEO of NABIP was the one that answered that question. Janet said, that's a different topic. Those are different companies, right? We're not saying if one healthcare provider versus another one offers a different price, that's a bad thing. She said it's when it's within the same ecosystem, right? So I think it's important for you folks listening to understand we're not saying all healthcare providers have to provide a service for the same rate, but what we are saying is if you're in the same ecosystem, the same provider group, the same network or hospital group, that's what we're talking about. So I just wanted to clarify that.
Yeah. So that'd be like going to Walmart and having milk on aisle 12 that costs $3 a gallon and milk on aisle 15 that costs $7 a gallon.
Exactly.
So, yeah, great point there. But, yeah, site-neutral transparency has to be brought to the forefront so people can become consumers of healthcare like they are for anything. Another one of our talking points is a way to update and innovate health savings accounts. I love health savings accounts, previously known as medical savings accounts, that were introduced back in 1997 through HIPAA. we think of HIPAA as privacy notices in our credit card statements, and yet HIPAA also brought us medical savings accounts and also tax-qualified long-term care. But HSAs were renamed around 2003 under the Medicare Modernization Act, and it allows for a lot of things to happen on a pre-tax basis. However, one of the things that occurred in 2020 during the public health emergency is that there was some forgiveness for things that were related to telehealth being paid for under a first dollar benefit through a health savings account. And that's a terrific idea. We talk about a shortage of providers, and yet we've got a whole bunch of providers that can really streamline their services through health, telehealth, and video health. And so now that the public health emergency is ending, those privileges of being able to pay for those types of coverage or services on a first dollar basis through an HSA are going to be taken away. We don't need to do that. We need to preserve the ability to pay for more things on a first dollar basis through a health savings account. Typically, a high deductible health plan will only allow for certain things like one preventive care service per year, or maybe even a small copay in an emergency room. We need to modify those rules and expand upon those rules. And for our Medicare producers that are listening, specifically in addition to HSA expansion, we also need to give people the ability to keep their high deductible health plan and continue to contribute to a health savings account, even if they enroll in a premium-free Part A of Medicare. And I get so many questions on this every day. Why is it that my working adults who own their own companies and have a high deductible health plan and they want to enroll in premium-free Part A, why is it that they cannot contribute to their health savings account anymore? It's very simple. It's because so many people that are working past age 65 today need that, but when these rules were developed 20, 30 years ago, there weren't that many people working past age 65. And as our society continues to age, and quite honestly, those 65-year-olds are really contributing a lot and running their own companies, it's a form of age discrimination when you tell someone, well, just because you are Medicare eligible and enrolled in premium-free Part A, you can't contribute to your HSA anymore. That's baloney. So we need to address that as well.
So your perception of that issue is it's not so much an intentional discrimination, rather it's kind of an oversight as things have just changed over time. People are living longer. It's just something that needs to be addressed.
Yes, it does.
Basically.
Mm-hmm.
Yeah.
And there are a couple of representatives that we've talked to about this that were actually doctors who are, of course, now representatives, but they also understand the value of a health savings account. And so we've got sponsors on both sides of the aisle. And just because now I need to point this out, this is the 118th Congress. So everything that we had going on in the 117th Congress ended at midnight on 12/31/22.
Mm-hmm.
So we had to start all over. And what's interesting is, you probably noticed this, of all of the congressional leaders and all of their staff members that really do the work, there was about a 50% turnover from the 117th to the 118th Congress. So now we have to go back and re-educate all these people. And that's kind of a good thing, because now all of a sudden you're bringing fresh ideas to 50% of the population that works on Capitol Hill, and they're much more receptive to being able to get behind something like this. So we're in the process of refiling a lot of the bills. Yes, we have to start over. But once we get those bills, then we can share them with our listeners and send out what's known as an Operation Shout. And when they receive this email, all they have to do is click the link, put in their home zip code. It'll pull up their representatives and senators, and there's a canned message that could be simply you type in your name and send it in to support every one of the issues that we're talking about here. And you know how it is when the phone rings in a congressional office, the staffers basically take note of whatever the topic may be, and then they collect yays and nays. And when it comes time for the representative or senator to vote, they look at their staff members and they say, okay, how do I vote on this issue? What do my constituents say about this particular issue? That could be a lot of different things, from gun control, border control, abortion, health care, health insurance, health savings accounts.
Mm-hmm.
They handle so many issues up on Capitol Hill. It's pretty dang amazing how smart these young folks are that are the staffers that really, truly do run this company or this country behind the scenes.
How can our listeners participate in that Operation Shout you were just talking about?
Well, if you're a NABIP member, you will get those Operation Shouts from time to time. and typically they are in support of or opposition of particular proposed legislation. They aren't really designed so much for regulations like some of the issues we'll talk about next, but I have been given permission by NABIP to send this out to all of our listeners and agents that we work with, even if they're not NABIP members, so that they can choose to say, yes, I agree with that, and if they don't, well, they don't have to support it. But if they do, and many of these issues are at the heartbeat of everything that we're all doing to try to bring affordable health care, affordable health insurance, affordable Medicare to the marketplace. So I would think that most people that would receive an operation shot, and if we ask them to support that, that would probably be in the category of a no-brainer in most cases.
Good. Okay. So you guys will be hearing from us soon then.
Yeah, absolutely, and often.
Cool.
So we would ask for everyone to pay attention to those. Another thing that we talked about, and this is unfortunate because, due to the public health emergency, we've seen the need for mental health services skyrocket. A lot of depression. We've heard of suicide rates, dependency, alcohol, drug usage, number of different things where people are trying to cope with what has been a super weird world since COVID knocked on our door. And I'll use the example of the brokerage here. We have a group health insurance plan that has mental health benefits. And the good news is the Affordable Care Act elevated mental health to be considered any other illness, no cap on annual maximums, whereas the old style plans may have had $25,000 annual maximums or whatever. It's going to be treated as any other illness. That's great. But the problem with that is we have a severe lack of mental health providers in the United States. And I'm not talking about just psychiatrists and psychologists, but also the folks who are at the doctor's office that are directing the patients, the RN that's directing the patients to the psychiatrist that might not be able to see you for 6 months. Well, if you've got somebody who has suicidal tendencies, that's probably not a good thing.
It's a little too long.
Yeah, but the problem is there's a severe lack of mental health providers in the United States. To that, I'm sure we can all agree. The problem as it relates to this issue, though, is if I don't provide our employees with an adequate mental health network of providers, then I, as an employer, am going to be on the hook to pay Department of Labor penalties every day. So that is super expensive and risky. So if I'm sitting there thinking, well, golly, I've got these super high expensive premiums with these ridiculous deductible coinsurance out of pockets, and I'm trying my best to just keep the plan in place, and now you're going to chunk a bunch of risk at me in the form of penalties because I'm trying to do the right thing, and there's a penalty for something I can't control, providing enough mental health providers, I'm just going to cancel my plan. And now I have avoided that risk. I'm just going to give everybody $500. And okay, great, maybe that'll work with ICRA, the Individual Covered Health Reimbursement Arrangements, and we're seeing a lot of growth in that area. But I don't want to cancel my group health plan. And the risk of doing so puts us as a nation right in the crosshairs of a single-payer system. That's a totally different podcast we could connect on. But we've got to preserve the employer-based healthcare system, the employer health insurance system. And so this mental health network provider risk there is another one of our big talking points.
That's just comes across as really strange to me, why that would be your problem, as an employer. Like, why is that on you to get that figured out and get that fixed? It's just strange to me.
Well, I think that there are a lot of well-intentioned people that go to D.C., and as you experienced, D.C. is a very powerful place, and yet it's a bubble. It's a bubble that's oftentimes very disconnected from what's happening back in the elected officials' districts. And that's why it's super important to make this point throughout this podcast and all throughout our conversations that our listeners need to get involved. Picking up the phone and calling their representative or senator and asking them to support a particular issue is very powerful. And people often think, I don't have time to do that. I don't know how to do that. Or they're not going to listen to me. I've heard all the excuses. Well, if you're afraid to do it or you don't know how to do it, there's this little thing called Zoom, and I could get on the phone with you and call them together, and you could introduce me, and I could speak on your behalf. So that's not an excuse anymore. We have to bring a voice to D.C. that says these are things that are impacting our affordability, access to coverage, and these are issues that you all have created, certainly unintentionally, but through additional regulations and legislations, there's always a cause and effect. And sometimes what happens is we end up going to D.C. and we're handed a list of these talking points, and we have to play defense. You know, imagine if you're a hockey team and you're playing against a penalty and you're one man down, and the whole time all you're structured for that 2-minute penalty is playing defense. There's hardly anybody that's going to be able to score a goal while they're playing one man down. And that's the handicap that we face when we go to D.C. Here's your talking points. Go play defense and fight all these things that happened.
In one day.
Well, we're going to have to start playing offense.
Yeah.
And that's a whole nother podcast. We could talk about that idea later. But we've got to be involved. And if these agents and brokers and customers that we're talking about do not get involved, you can expect more of this unintentional stuff to happen. It's not going to do anything but drive up cost and limit access to health care.
The bubble analogy is probably the best one. I mean, thankfully, the brokerage, after all their years of success, is a profitable company and thankfully can afford to support their employees. But, man, you got to think about those small businesses that are just barely able to afford those group premiums at all. Mm-hmm. And you know, whatever industry they're in. The point I'm trying to make is, you know, you guys are listening, you're in the health insurance, Medicare industry, but the truth of the matter is our little industry here is not little, and it actually affects every business owner in America, every employee in America, and at the end of the day, our quality of life. And so, you know, when you participate in NABIP and the things we're talking about, you're not just talking about health insurance. What you're really talking about is our finances as a country. I mean, truthfully.
Absolutely. Well, you know, our podcast here kind of has 3 buckets of topics. One is the employer health, which we've kind of spent the last 10, 20 minutes talking about. The next one is individual and family coverage. And the third one is Medicare. And so let's switch over to the middle bucket here, talk a little bit about the ACA. I would also encourage our listeners to understand that the brokerage as a CE provider in the state of Texas recently gained approval on a brand new 1-hour CE, and that's about Medicaid redetermination, or what's called unwinding. In a nutshell, basically what happened back in 2020 when the public health emergency was declared, a lot of people that were on the borderline of being Medicaid eligible were granted Medicaid eligibility so that they could have access to vaccines and health care and things of that nature. Well, a lot of those people might also be covered under a group health plan or be eligible for some other form of insurance. And so the redetermination, which begins on April 1st, 2023, is basically going to audit over 15 million people to say you're either still eligible for Medicaid or perhaps you're not, but maybe your kids are now eligible for CHIP, or maybe you're not, but you're eligible for an ACA plan, or maybe you're not eligible for Medicaid because you have a group health plan. But what this is going to do over the next 12 to 14 months is it's going to turn upside down a lot of people's lives, not to mention just those who have Medicaid. What about the payers? What about the people who fill the prescriptions or provide the health care? And they're used to sending it to Medicaid for payment. Now, all of a sudden, Medicaid's going to shut down that pharmacy or shut down that doctor and say, we don't pay those claims anymore. And that's going to create a huge opportunity for our brokers. The family glitch prevented that from happening. Well, that was removed last year, and now we can go out and actually help dependents who might have no coverage because they couldn't afford to be on the employer plan, and we can use a special enrollment period to bring those people into the ACA with an individual family plan. So there's 2 huge ways that you can help uninsured people to gain affordable coverage. So not that we're going to talk about that here, but I just want to let people know if they're interested in us performing that 1-hour CE class for either their staff, their office, or perhaps they belong to a business association or another professional association, give us a buzz and let's talk about that. The third bucket is Medicare. And our talking points at the CAP conference included a lot of activity. First of all, I want to say this. When the National Association of Health Underwriters was founded years and years, decades ago, it concentrated on employer group health plans. anything from group health insurance to group disability, but it was employer-based. And the common complaint that I would hear out of individual health insurance producers or Medicare producers is, y'all don't do enough for Medicare. Well, when I took over as the chairman of the Medicare Advisory Group 4 or 5 years ago, that was one of my goals, was to make sure that when people thought of now NABIP, they would think of Medicare as well. So we had
I think it worked.
Absolutely.
Yeah.
And happy, man, because, gosh, let's face it, everybody knows, okay, 10,000 baby boomers are aging in every day. It's really a lot more than that. And that's going to continue for another 5 or 6 years. So for those agents that are sitting on the sidelines thinking, I probably missed the boat on Medicare. No, you didn't. Jump in, the water's fine. We can help you and make it easy to start representing Medicare-related products. But specific to our talking points, last year was a tough year. That was when CMS decided to create new regulations. Key thing, not legislation. They just decided to create brand new regulations. Why? Because the complaints to Medicare went from around 20,000 in 2021 to 40,000 or so in 2022. Now, if you have a calculator, I humbly submit you might want to figure this. Take that number of 64 million Medicare beneficiaries, and 40,000 of them made a complaint to Medicare. I'm going to suggest that's the phrase majoring on the minors. But CMS decided they had to address this with new regulations. Most of that was created by things when people called the 1-800 number on their TV to a third-party marketing organization, TPMO. And at the crux of the issue was agents and brokers were put into the definition of a TPMO. And we could spend an hour telling the differences between a TPMO and an independent agent. So to do that was a mismatch, an overstep of their authority at CMS to create new regulations that frankly just don't really address the problem. The problem's created by call centers, some of which don't even exist in the United States. You ever received a telemarketing phone call, and that phone number that you look at is something that you can't even call back because it's an IP address, it's a ghost.
Yep.
And that created the problem. But we as agents had to suffer from that. So we are asking for Congress to enact new legislation that will remove the definition of an agent and broker. So we have to create legislation to address onerous regulations. This is really an issue. So we have some support. Senator Rounds out of South Dakota has sponsored a bill. Again, that was quashed at the end of the last year. So a new bill, it was S5149, is going to be refiled, and we will have bipartisan support. Of course, we'll send out an Operation Shout to just remove the simple definition, the agent and broker out of the definition of a TPMO. This is an easy fix, right? So that was one of our main talking points. In fact, my Congressman Burgess out of District 26 here in Texas, when I was talking to his staffer, she looked at me and she said, "That's crazy." She said, "My parents both just got licensed." I intend to recruit them, by the way. But she said, "They just got licensed." I said, "Well, your parents are now going to have to record their phone calls if they help a Medicare beneficiary with certain health plans and drug plans." And she said, "That's crazy." I said, "Yeah, that's crazy with a capital C." But that's what's happening. The overall atmosphere right now in D.C. is that we'll just address it with additional regulations. We'll fix that problem. And it's costing us as business people additional time and money to record and store those calls. So let's get rid of that. The other thing, and this seems to be an annual thing that we argue about, is having COBRA to be treated as creditable coverage. COBRA is available for groups of 20 or more that have had a group health plan, and they can extend their group health plan benefits when they leave their employment, depending on the situation, anywhere from 18 to 36 months. Interestingly, Part D as in drug is okay. That won't cause any issues, but the Part B as in boy is not considered creditable coverage. So let me use an example. Let's say that someone comes to me, they have cancer. They have to leave their employment to go to treatment, all right? They need to take COBRA, but they don't want to take Medicare because some of their providers might not take Medicare.
Okay.
So they don't take Medicare. And then 1 year later, they're treatment-free, everything's good, and they want to enroll in Medicare.
Mm-hmm.
Well, unfortunately, COBRA's not creditable coverage. So in that period of time where they didn't have Medicare, Medicare would have been the primary payer. COBRA
Right.
is a secondary payer.
Right.
So those providers could easily file with the COBRA company, and COBRA could come back and say, hey, we don't have to pay those claims. That person has an eligibility for Medicare. So Medicare would be a primary payer in that event. So number one, that leaves that Medicare beneficiary very exposed. And number two, as we all know, if you don't take Part B, when you're eligible after 12 months, you carry a 10% penalty for the rest of your life. That could be super expensive. This is ridiculous that we have this exposure and this amount of conversation regarding this issue. The simple fix is make COBRA creditable coverage. There is no reason why it shouldn't be. So let's just
it's
get
coverage. Yeah.
Yes, it's comprehensive major medical coverage.
Yeah.
Oh, hey, by the way, if your budgets are so strained at Medicare, wouldn't it be a good idea to give an option to people
Sure.
for COBRA so that they don't go on Medicare any sooner than they have to?
Right.
Common sense.
That's very like it's almost comical, actually, that's an issue. You know what's heartbreaking, though, is how many people probably find themselves in that situation and they just didn't know because nobody told them. Because most folks probably don't even know about this. This isn't just like street knowledge here.
I could tell you so many bad examples, and that's one of the best ways for our listeners to help.
Yeah.
Is to have the constituents in their area, people that they serve, call that have been burned by this and say, because of this, I got exposed. I got a bill for $100,000 for chemotherapy because I didn't take Part B.
Gosh. And they're right there at that final quarter of their life, too.
Yeah.
Like, what a bad time to get financially. Like, you don't have a lot of time to recover.
Yeah.
You know?
Well, and the problem is they make more regulations on top of more regulations. It's kind of like a person that takes one more medication. Now this is going to cause another side effect, so one more medication has to be prescribed to offset the new side effect. It's onerous.
We got to fix this one.
It's simple.
Yeah.
Another big issue, a big talking point, is observation status. Observation status, simply put, is, I'll give an example. Let's say that a person has chest pain and they go to the emergency room. Let me tell you, you present in an ER with chest pains, you go to the top of the list. I don't care if your finger's bleeding all over the floor. The heart patient's going to the top of the list. Mm-hmm. Immediately, they hook them up to a lot of machines, and maybe 5 hours or 25 hours later, they find out that they really weren't having a heart attack. They just had too many nachos for dinner, and they were having heartburn.
Yeah.
So they might need to take some omeprazole and Tums. But by golly, in the meantime, there's been $30,000 or $40,000 worth of tests run on them. And then what happens? They're discharged, and they go home. They were not admitted as an inpatient, yet they've been there for maybe more than 24 hours. And they weren't necessarily an outpatient either because that little ER is kind of a gray area. Next thing you know, about 3 weeks later, they get a surprise bill in the mail for $30,000. Who's going to pay that? It's a problem. That's part of the problem. The other part of the problem, though, is if a person is admitted to a skilled nursing facility, that has to be preceded by an approved Medicare 3-day hospital stay. So you've got to be in the hospital for 3 days in order to be in a skilled nursing facility. And that's a problem because a lot of people are not going to need a hospitalization or they've never been coded as an inpatient. Next thing you know, the skilled nursing facility says, well, we don't have to treat this person because they can't afford to pay. And this is a really big problem, especially when a readmission occurs. If you think of someone who may have a chronic condition, maybe they're diabetic or they've had a stroke, and they go in and out of the emergency room, and then eventually they're going to need physical therapy, speech therapy, occupational therapy, and most of that's provided in a skilled nursing facility setting. But if they don't have a previous 3-day hospital stay for every one of those skilled nursing facility admissions, they're going to be on the hook to pay those claims. That's crazy.
That's a little, that's kind of dark.
It is. And like you said, here are these people on the back nine of their life, so to speak, and now you're punching them with a bunch of unexpected bills. These are the unintended consequences that need to be addressed.
And to make sure I understand you, you're saying I stay in the hospital for 2 days go home, have a repeat issue, that clock resets again.
Yep.
And if I don't stay for 3 days, wow.
Yeah, what were you doing in 1965 when that rule was written?
Somewhere in non-existence, I don't know.
So my math is maybe off, but is that about a 58-year-old rule?
Sounds like it.
Yeah, so it's time to change that.
Yeah.
Okay, so observation status. And then one of the last talking points that we had, I know a lot of our listeners will relate to this easy, is we are in the first 3 months of every year known as the Medicare Advantage open enrollment period. And we all know from our excessive certification classes that the MA OEP allows for us to switch certain plans. Like, for example, if you want to go from one Medicare Advantage plan to another Medicare Advantage plan, or from Medicare Advantage back to original Medicare. But what's the one thing you can't switch during that first 3 months of the year?
Your PDP, right?
Your drug plan, PDP. And here's why this is going to be an increasingly risky proposition. The Inflation Reduction Act, which was passed last September, brought change to the structure of Part D, including a $2,000 max out of pocket in 2025, $35 insulin copays, how we treat the catastrophic phase of Part D, and it really made some structural improvements for the Medicare beneficiaries, but that's going to create significant pressures on the PDP providers in the form of additional risk and an inability to raise the premium because there's a 6% cap on premiums as well. And part of these problems is that when a person goes to the pharmacy in the first couple of weeks or couple of months of the year, what they might have been paying $10 for, now all of a sudden is a $100 copay. Because believe me, Part D changes are coming. Mark my words, this next open enrollment period, the AEP 2024, we will see significantly different PDP structures. And there's going to be a lot of movement.
Because they're making up the difference.
That's right.
On some of these other caps.
They took the air and squeezed it from one side of the balloon. That air didn't leave the balloon, buddy. Pharma's getting paid.
Right.
Big Pharma's going to get paid.
Yeah.
And so that said, when a person loses the ability to change their drug plan during those first 3 months of the year, they're going to be stuck paying higher copays. And some of these people are on fixed incomes.
Yeah. Why
not just add PDP to the ability to change in the first 3 months of the year? Simple common sense fixes.
Mm-hmm.
So you've heard the expression, sometimes you get too close to the forest to see the trees.
Mm-hmm.
Okay, well, the people in D.C. live in the forest. They can't see the trees. And that's why we have to bring that voice of reason back to them and say, hey, folks, time out. We need to reset here on some of these things that are unintended consequences that could be fixed with easy regulations. You tell me that can't be fixed with regulations? Well, let me ask you then, how come you're able to just throw agents and brokers into the definition of a TPMO? You created the regulations that were convenient for you, but when I ask you to change to help the beneficiaries you represent, you can't change the regulations? That doesn't make sense to me. I'm listening. Help me understand that.
Mm-hmm.
That's where our voice of reason comes in. And that's why it's so darn important that we, the brokerage, continue to go back to D.C. and advocate on behalf of our agents, brokers, and all of the people that they serve for group health insurance, Affordable Care Act plans, and Medicare plans.
All right, folks. Well, this has been a lot of information that we've been throwing at you, and we're not going to stop here. We actually have 2 other podcasts that are going to come out of this one about the Medicaid redetermination, and then the other one about the family glitch. So make sure you stay tuned to hear those coming up soon. But Mike, thank you so much for sharing this with us. Anything you want to add to close us out today?
I just want to encourage anyone listening to this to take that link in their podcast and send it out to as many of their friends, relatives, fellow brokers, and share this message. Because it was a very expensive proposition to take 7, 8 people up there to D.C. and be out of the office for 4 or 5 days. But it's very important that we continue to do this. So help us to spread the word.
Awesome. Great message. Cool. And then I'll do an outro later. Okay.